Thank you, everybody. Good afternoon. I'm Dilip Thakar from Houston, MD Anderson Cancer Center. And the topic I'm given is, let me see if I can move it forward. Yeah, this is the topic, the dynamic changes during the one-lung ventilation. And basically, this, again, deals with the physiology of one-lung ventilation, what happens during the interaction between the heart and lung. We had a presentation yesterday. It was a workshop. Again, the basic concept for this talk is physiology of the lung, the heart, and the pulmonary circulation. So that's what I'm going to talk about. So just to start with, we do fair number of thoracic lung cases where we do the wedge resections, lobectomy, pneumonectomies, and also some of the non-pulmonary surgeries like esophageal surgery, the vascular surgeries, things like that. So we always have to think about the cardiopulmonary interactions and the one-lung ventilation. So I'm going to start with the case number one, 18-year-old child with a history of metastatic osteosarcoma to the hilum of the lung, involving the right main stem bronchus and obstructing the right pulmonary artery completely. The patient had a past medical history, which was significant for the multiple wedge resection. And one of the important things patient had was WPW syndrome. And that was one of the concerns we had as far as the cardiac problems were concerned. So as you can see here, the chest X-ray of a kid who is 17-year-old, there's a large mass in the right hilar area, which is about 48.6 millimeter in diameter. If you look at the CT scan, same thing, a pretty significant mass in the right hilar area, compression of the right main stem bronchus, the right pulmonary artery, which is right here, which is completely obstructed on the right side, which shows you that there is not much of a flow on the right side. So on the preoperative testing, the hemoglobin was 9, coagulation profiles were normal, electrolytes were normal. The important things we look for these patients is the pulmonary function spirometer and plethysmography. So pulmonary function shows FEV1 51%, FVC 52%, max minute ventilation was 64, and DLCO 63%. Everything is a borderline for the pneumonectomy. Since this patient was scheduled for the pneumonectomy, all the parameters are just on the borderline. So questionable is, will this patient tolerate pneumonectomy, was one of the concern. The cardiopulmonary exercise testing shows the peak of VO2, 15 ml, and 30% of the maximum capacity, and anaerobic threshold was 20% of the maximum capacity. If you look at the perfusion scan, which was very important in this kid because we are doing pneumonectomy, we need to know that what is the perfusion on the disease side versus the healthy side. And as you can see here, the patient had a right pneumonectomy, was scheduled for right pneumonectomy, and you can see the right upper lobe zone, the lower zone, and the total lung perfusion on the right side was only 3.94%. So there was no perfusion, as you can see, on the right lung, which is a good news because that helps you that how this patient is going to do intraoperatively when you go on the one lung ventilation for the surgery, because you expect that the 3.9% total perfusion on the right side, there won't be much of a shunt going on. So I think looking at the preoperative VQ scan or perfusion scan is very important. And this was the EKG, as you can. This is a classic WPW syndrome, and this patient has a P, short PR interval, wide QRX, and delta wave, all consistent there. Pre-op echo was also normal. The LVRV functions, the valvular functions, PA pressures were slightly elevated, 35 by 12, but again, nothing significant to be concerned about. So this patient was scheduled to undergo median sternotomy because it's a hilar mass, right pneumonectomy, pericardial resection, and a reconstruction. Resection of the superior vena cava, because the tumor was also involving the superior vena cava, and reconstruction of the superior vena cava with application of the muscle flap on the right mainstem bronchus to strengthen the stoma after the surgery. That was the procedure. Anesthesia-wise, this patient received general endotracheal anesthesia, double lumen tube, arterial blood pressure, LITCO, non-invasive monitor. CVC line was placed in the femoral area because the superior vena cava was supposed to be resected. TE was performed for the entire period because of the hemodynamic monitoring, EBL 1500. Transfusion was given about 4 units. Patient was extubated. The plan was to begin with was to extubate the patient in the operating room, considering all the other risk factors involved. That really the best place to extubate him. And then transfer the patient to the PACU and to the floor, and that was done. Patient was extubated, taken to the regular recovery room, and then transferred to the normal room after the surgery. So the reason I presented this case is there's so much involved in this patient's preparation. He had multiple surgery. Now he comes for the major surgery, which is median sternotomy and resection of the lung. You have to be prepared for any kind of cardiac, any kind of pulmonary, or any type of perfusion-related problems with the lung. So what are usually the concerns about thoracic surgery when the patient comes to you preoperatively? You have to know the normal physiology. What happens to these patients when they're in the lateral decubitus position? What happens to the pulmonary circulation? How do you manage their ventilation? You know, you learn nowadays about the lung protective strategies, what ventilation strategies you're going to use on one lung, how you're going to manage the hypoxic pulmonary vasoconstriction, what happens to the shunt, what can increase or decrease the shunt, what about the dead space, how do you manage the VQ mismatch, what hemodynamic challenges can come, especially the right ventricle, because now you're thinking about collapse of the right side of the lung, and then what happens to the pulmonary vascular resistance, what happens to the RV afterload, all those things, fluid management, and what are the drugs and anesthetic agents which you're going to use can affect all the things which you're thinking about the VQ mismatch in this patient. So those are important concerns. And so considering that, you need to know what are the predictors of intraoperative hypoxia during one lung ventilation. These are some of the predictors, especially the functional status. Somebody comes to you who is a little older gentleman, history of smoking, COPD, or some sort of other lung disease, may have a higher chance of having some intraoperative hypoxia. ASA status, how much lung you're going to resect in these patients. Are you going to do lobectomy versus pneumonectomy? That makes a difference, so multiple wedge resections. Left versus right, you know that the right lung has a more perfusion, so if you're doing a right lung resection, you're going to have a little bit higher risk of having a hypoxia during the one lung ventilation. Pre-op PFTs, DLCO, VQ match, again, helps you. Tumor, is it a central or peripheral tumor? Helps you, because if it's a central tumor, then you will see that the central tumors usually are close to the pulmonary arteries, and usually compression, in this case what you had, will cause decreased perfusion to the diseased lung. As a result, you will have a less shunt, and you have a less hypoxia during the case. And currently, you know, in our practice, at least the incidence of hypoxia, which we think is anytime oxygen saturation less than 90%, we think it's a hypoxemia. The incidence has gone down because of the change in our practice, the change in the way we do the one lung ventilation, the way the surgeons handle the lung intraoperatively. All those has helped to decrease the incidence of intraoperative hypoxia to about 4% in our practice. So this was one of the study done. Published in Anesthesiology in 1992. This was a Japanese group of people who had done the study. And so what was the effect of positive pressure ventilation on hemodynamics and right ventricular function? And they looked at the 20 adult patients for thoracotomy. All had a surgery in lateral decubitus position, Everybody had a double lumen tube. The anesthesia was maintained with isoflurane and nitrous oxide, and mechanical ventilation was done with the intention that the peak pressure should not exceed 20 centimeter of water in every patient. The PA catheter was placed to sort of have numbers, cardiac output, cardiac index, ejection fraction, and pulmonary artery pressures. And measurements were done in 5 different stages of anesthesia. The 2 measurements were done during inspiration and expiration during 2-lung ventilation. 2 measurements were done during inspiration and expiration during 1-lung ventilation. And the 1 measurement was done in open chest with 1-lung ventilation. So just to compare what happens to the hemodynamics. And this was the result they found. What they saw was at the same peak airway pressure, both the 2-lung and 1-lung ventilation, there was a depression of the RV function, and the systemic hemodynamic was low in both cases, single and double lung. But the 2-lung ventilation depresses hemodynamics more than the 1-lung ventilation. That was their thought. There was no difference between the closed chest and the open chest during the 1-lung ventilation in the hemodynamics. 1-lung ventilation had less cardiac adverse event than the 2-lung ventilation. That's kind of interesting how that happens. So their conclusion was that the increase in the peak airway pressure limits the dependent lung perfusion. Basically, you're limiting the dependent lung perfusion because of, traditionally people have used 10 cc's per kilo tidal volume, PEEP and all that. But the newer recommendations say you don't want to use that much. We use 5 to 6 cc's per kilo. So those higher peak airway pressure limits the perfusion of the dependent lung at the same time and increases the shunt to the non-dependent side. And because of the non-dependent acts as a conduit of low resistance, there is increase in the shunt and less increase in the afterload to the right ventricle. And that was their explanation, that they did not see much changes in the right ventricular dysfunction. This was a second group of people who changed the hemodynamic changes during the VATS procedure and the effect of 1-lung ventilation compared with the capnothorex. So at our institution also, in a selected group of patients, we use in our practice, we always use double lumen tube or some sort of mechanics where we do 1-lung ventilation. And occasionally surgeon will say, lung is still not compressing and he needs complete atelectasis of the lung. And they will say, okay, let's use some CO2 or capnothorex to compress the lung. But in those cases, we really want to watch the hemodynamics because that's one of our concerns. So these people, group of people have looked at pure capnothorex and 2-lung ventilation, capnothorex, and do some minor procedure like pleurectomies and a biopsy, which some small procedures. They have selected the patients whose FEV1 average was 93% and forced vital capacity was 91%. And echo was normal. So they just want to see what happens with the capnothorex. Anesthetic and surgical management was pretty much same in all the patients. DLT, TIVA, mechanical ventilation with FiO2 50%. And the tidal volume was varying anywhere from 10 cc to 6 cc's per kilo. Pulmonary artery pressure was used. CO2 insufflation was done in stages 5, 10, and 15 millimeter of mercury. And data were collected during induction, lateral decubitus position, during the capnothorex, and 1-lung ventilation. And hemodynamics data were collected to see cardiac index, ejection fraction, CVP, PA pressures, and the wedge pressures. And also they also checked the mixed venous oxygen saturation and ABG. This was their results. They're able to do only 4 patients for the surgical access with 2-lung ventilation and capnothorex because they could not completely collapse or have a good surgical access to what they wanted to do. So they could do only 4 with capnothorex. The remaining 9 patients, they had to do a 1-lung ventilation. And their conclusion was that there is a significant hemodynamic changes when you do the capnothorex, hemodynamic. But if you don't do capnothorex, if you do 1-lung ventilation, there is a significant decrease in oxygen saturation. So the PF ratio was lower in one lung ventilation versus the capnothorex patients. But there was no difference between the LV and RV side surgery, which is left side or right side surgery. But I think their conclusion was that capnothorex, mainly, you have to concern about the hemodynamic compression. It acts like a tension pneumothorax when you do that. So especially if you're increasing from 5, 10 to 15 millimeter of mercury capnothorax. That brings to a topic to know, okay, what are the different zones? What is the pulmonary circulation? We need to know. How does it act? So west zones are classically described as zone 1, 2, 3, 4. What happens to the west zone? There is a variable flow during the cardiac cycle. If you think about zone 1, 2, 3, 4, zone 1 has the highest pulmonary alveolar pressure, then pulmonary arterial pressure, and then the venous pressure. Zone 2 has higher arterial pressure, alveolar pressure, and the venous pressure. Zone 3 has higher arterial pressure, venous pressure, alveolar pressure. And there is a zone 4 as well. The zone 4 has higher arterial pressure, interstitial pressure, then venous pressure, and alveolar pressure. All these zones are interchangeable. Basically, zone 1 and 2 can be changed to zone 3 depending upon your cardiac output and hyperdynamic heart function or exercise. When you do that, your perfusion to the upper part of the lung increases, and that changes the zone. Also, if you, in a systole and a diastole, sort of the zone will change. The zone 2, as you all know, it's called watershed zone, that changes with the how much ventilation is happening and what are the pulmonary artery pressures. So those zones are very important to remember in supine, in a lateral decubitus position, in the prone position. All those things affects those zones. The perfusion to the lung is heterogeneous. So, and also the ventilation is not homogeneous in the entire lung. So that's something we all have to keep that in mind. So these are the typical zone 1, 2, 3, 4 of the lung. And when patient is standing, these are the zones when the patient is on the side. And this again depicts, this was a study done by the radionuclide angiography, and they show that this was the people who were exercising and preparing themselves to climb the Mount Everest. And there was a place in England where these people routinely go under cardiopulmonary exercise testing to see what is their peak VO2 and what is their anaerobic threshold, and sort of train themselves based on that. And they looked at some of the people who go there will develop pulmonary edema, and some people don't. And so they were looking at the perfusion scan, and they found out that those people who have more heterogeneous flow in the lung will have higher risk of developing pulmonary edema versus those people who have more homogeneous circulation in the lung. So what happens with the gravity? As you can see in this picture, the effect of the gravity. Your dependent lung, let's say this is a right and this is a left lung, usually you have 55% flow. This is 45%, or this is 50, this is 40. Now, once you have a dependent position, you get a little more, about 10% more blood flow to the dependent lung. And as a result of that, you will see, plus this is a two-lung ventilation. When you switch it from two-lung to one-lung ventilation here, non-dependent to dependent lung, first thing is your shunt has increased from 10% to about 27 or 30%, which is typical in a healthy subject. And that, again, that plus the ventilation will change depending upon spontaneous versus the mechanical ventilation. In spontaneously breathing in a lateral decubitus position, you have more ventilation here and more perfusion here. Whereas in mechanically ventilated patient, you have more perfusion here and more ventilation going on the top. At the same time, you have to think about what is happening, the dynamic changes. You have these things happening, like you have the diaphragm on the dependent side pushed in. You have the part of the chest wall which is pushing up. you have a mediastinal structures which is pushing down that lung. Overall, that is decreasing the functional residual capacity of that lung, again, causing some VQ mismatch. So this picture depicts what happens in all the three. This is a closed chest. This is a closed chest with positive pressure ventilation. This is spontaneous ventilation. And this is another situation where you have a anesthetized patient with an open chest. And as you can see, the perfusion, the VQ mismatch is the best in this situation. And as you go these two situations, the VQ gets worse. Again, you have to think about what happens to the top of the lung and what happens to the bottom of the lung. As you can see here, the ventilation is still the highest in the lower part of the lung. The alveolar ventilation is 0.8, 0.2. The perfusion is still highest in the bottom of the lung. This is in the normal physiological spontaneously breathing person. If you look at the VQ match, which is lower, 0.63, because the perfusion is still much higher in the lower lobe than the ventilation. And PO2, if you think about, because the ventilation is much higher here, PO2 is higher, here is low. So traditionally, if you draw the blood sample from the lower lobe, you'll be hypoxic and hypercarbic gas mixture in the lower part of the lung, where if you go on the top part of the lung, you have more oxygenation and less of a CO2. Just give you another example of some theoretical demonstration of hypoxic pulmonary vasoconstriction, what happens with the shunt. This is the picture. You have a normal VQ match, spontaneously breathing, both lungs are ventilating. You have blood going in, coming out, almost 98% saturation, and you have a VQ ratio is almost 1. VQ ratio is almost 1. This is another situation here where you have no hypoxic pulmonary vasoconstriction, but decrease in the ventilation. So you can see there is some venous admixture going on here. So your VQ ratio will be lower here, and the saturation will be low. This is a third situation here where you have now, as opposed to this, you have low ventilation, but you have partial hypoxic pulmonary vasoconstriction. And here, no ventilation, you have a maximum hypoxic pulmonary vasoconstriction. So what happens to the blood gases all depends upon how much shunt you have from this side to this side and how much ventilation is happening. That all adds up to get you the final result. If more venous admixture you have, more desaturations you're going to get, and which is the most common thing happens in one lung ventilation. So what are the factors which affects the hypoxic pulmonary vasoconstriction? Anesthetic modifiers, that's one big controversial subject, that inhalation agents does that, inhibits hypoxic pulmonary vasoconstriction at a higher MAC. TIVA doesn't do that. Cardiac output does affect. The extremes of cardiac output can change the mixed venous oxygen saturation. PEEP, CPAP, higher pressures can increase the venous admixture. Patient factors, especially the older age, can do that. CO2, hypercarbia is okay, but the hypocarbia or alkalosis can worsen the venous admixture. Hypothermia versus hypothermia. People have looked at the people who go for the higher altitude, especially the Everest people, when they go, they hyperventilate and hypothermic. That actually causes vasodilatation. So hypothermia under hypoxic condition will cause vasodilation, but hypothermia under normoxic condition will cause vasoconstrictions. Of course, hemodilution is not good. Again, it'll inhibit the vasoconstriction. Drugs, there are multiple drugs listed which affects your hypoxic pulmonary vasoconstriction. And of course, surgical manipulation. More surgical manipulation is done, then more causes inflammation and release of more nitric oxide, prostacyclins and other drugs, endothelin and all that, and that will cause, again, worsening of the hypoxic pulmonary vasoconstriction. This is just the, do I have time or I'm running out? 5 minutes? Perfect. This is just a graphic depiction of what happens when you go on the one lung ventilation. When you initiate the one lung ventilation, you have immediate, within seconds or minute, you get hypoxic pulmonary vasoconstriction. And as you continue, within about 45 to 60 minutes, you get a nice slope of progressive increase in pulmonary vasoconstriction. It continues as long as the surgery proceeds. And what happens is, once you stop the surgery, once you inflate the other lung, the hypoxic pulmonary vasoconstriction starts to disappear, because now you're oxygenating the lung back again. And then it takes about 60 to 90 minutes to have the complete recovery of the vessels which were constricted because of hypoxic pulmonary vasoconstriction. So the importance of this is that if you have a patient, you are doing lung volume reduction surgery, both sides, median sternotomy, and you are alternating the lung ventilation, you may have more hypoxia, because what happens is your lung takes a longer time to recover from the hypoxic pulmonary vasoconstriction. So you did a right lung surgery, now you're doing the left side. Right lung still has hypoxic pulmonary vasoconstriction there. So when you're doing ventilation of the right lung, it'll take some time. And that's the reason that you're going to have a prolonged hypoxia. Again, this was another study done by a group of people in Japan. They looked at it, how much lung you should have to have a good hypoxic pulmonary vasoconstriction. And as I mentioned, the most potent stimulus for the hypoxic pulmonary vasoconstriction is the partial pressure of oxygen in the alveoli. That is number one. Number two is partial pressure of oxygen and the mixed venous oxygen saturation in the venous blood. That is a very strong stimulus. And the third factor, which really helps to have really good vasoconstriction and decrease the shunt, is atelectasis. If you have a good atelectasis of the lung, you will get a really nice constriction and increase in the resistance to the blood supply to the non-dependent lung, and you'll have a better oxygenation. So these are the three most important factors you have to consider in mind. Again, mechanical ventilation does affect your vascular resistance. This is the dependent lung. So if you're using a dependent lung ventilation, your extremes of ventilation, this is the lowest part of the exhalation and this is the inhalation, you will have the highest amount of resistance to the pulmonary blood flow. Here is the FRC. So the FRC, you have the lowest resistance to the blood flow in the dependent lung. And why this variation? Because you have two groups of blood vessels in the lung. One is alveolar and one is an extra alveolar. So during the inspiration here, you have decreased resistance into the extra-alveolar blood vessels. And here, you have increased resistance to the alveolar blood vessels. So both matches up, and you get the combined result from addition of the both resistance. But one you have to keep in mind that at the FRC, you have the lowest vascular resistance. Again, what is the effect of cardiac output? Here it shows that traditionally we think that, patient has low cardiac output, increase the cardiac output, you'll have better oxygenation, but that's not the case in this situation. Extremes of cardiac output, as you can see here, low cardiac output and high cardiac output. If you keep increasing the cardiac output, your shunt will increase. Your mixed venous oxygen saturation increases, and again from here, if you mix and venous saturation increases much more, then you'll see your partial pressure of oxygen starts coming down. Because what happens is, as I mentioned, the mixed venous oxygen saturation and the partial pressure of oxygen in mixed venous blood also acts as a stimulus to the hypoxic pulmonary vasoconstriction. So you really have to be careful in how much inotropic agent you want to give. Too much is not good. This was a study done to see the effect of iron infusion in the patient, especially the patients who are anemic, pulmonary hypertension, or patients who are going to the high altitude. Those are the patients who are, if they are anemic, they found that they will have a high response to the hypoxic pulmonary vasoconstriction. This is normoxia and this is hypoxia. And once they transfuse them with the iron, their hypoxic pulmonary vasoconstriction response was much lower, or almost nil. So the effect of iron, for some reason, was very, very interesting on these patients. These are some of the group of drugs I have listed here. They're, anesthetic agents, inotropic agents, vasodilators, a group of drug which affects the hypoxic pulmonary vasoconstriction. So in conclusion, what I would like to say is alveolar partial pressure is a predominant stimulus to the hypoxic pulmonary vasoconstriction. Partial pressure of oxygen in the mixed venous blood also plays a very important role. Think about the sepsis. Size of atelectasis is very important. Lung volume determines the PVR. If you have a higher volume on the ventilation, it will increase the PVR and increase the shunt. Anesthetic technique plays a minor role. Maintaining the cardiac output optimal level is very important. Shunt is usually the common cause of hypoxia once you have ruled out the other possibilities. And another thing to remember is patients who have a normal distribution of perfusion before the surgery tend to be more hypoxic during the one lung ventilation than who have a reduced flow in a diseased lung. So like the case I showed you, he had almost shunt 4% prior to the surgery. So those are the ones who will have less incidence of hypoxia. And RV function is usually the well-maintained during one lung ventilation. It's not a problem. Thank you.